We're going to hear now from Dr. Larissa Nekhlyudov. Dr. Nekhlyudov is a professor of medicine at Harvard Medical School and the clinical director of internal medicine for cancer survivors at the Dana-Farber Cancer Institute in Boston. She provides care for long-term survivors of both childhood and adult cancers and has dedicated her career to improving cancer survivorship care and strengthening the connection between primary and oncology care. Please join me in welcoming Dr. Larissa Nekhlyudov. I always take the short way.
Oh, yeah, well, yeah.
Thank you.
A little height challenge, so. All right, good morning, everyone. I am really honored to be with you here today. And for the next 50 minutes, I will be fully in the present, as I will be here with you and sharing with you sort of my knowledge and experience as a clinician caring for cancer survivors. But I am honored to speak before you as cancer survivors and caregivers. So it's really amazing that this is the 20th anniversary of this meeting. So for those of you who may not know, the Institute of Medicine published its sort of key book. We call it the Bible of Cancer Survivorship, and that was published in 2006. And we're now celebrating 20 years since the publishing of that report. And it's really amazing that cancer survivorship was on the map here in Minneapolis, even, sort of as it was just getting to the national stage. So congratulations to the conveners of this conference for over 20 years for keeping this emphasis. So my presentation today will be Living with and Beyond Cancer, a whole person approach to cancer survivorship care. And so, as already alluded to today, a cancer survivor is an individual from the time of diagnosis through the balance of life. But this definition from the National Cancer Institute really sort of spans the continuum of cancer survivorship. And there are different types of cancer survivors, those who are treated for early stage disease and may be cured, those who may have advanced or metastatic cancer and may constantly be in the state of treatment, and then those who are at the end of life and really in the palliative care phase of cancer survivorship care. But I want to highlight what is italicized here is that this term is meant to capture a population of those with a history of cancer rather than to provide a label that may or may not resonate with individuals. So if you're here today and you identify as a cancer survivor, great. If you are here today and you say cancer survivorship sucks and I'm not a survivor, that's fine too. And really it doesn't really matter. Really the label is for us in the field of survivorship, but it's not meant to label anyone here at all. And so I will throw out a few statistics, but I promise I will not bore you with statistics. So there are now 18.6 million cancer survivors in the US, right? So those are all the individuals living with and beyond cancer diagnosis. But the statistics show that the number of cancer survivors will only continue to grow, and that's great. The treatment for cancer has improved. However, unfortunately, there are some populations where cancer diagnoses are going up, particularly in the young population, especially colorectal cancer and to some extent breast cancer as well. And in terms of the age or the years since the diagnosis, so about 70% of cancer survivors have lived 5+ years since diagnosis. 49% 10 years, and 22% have lived more than 20 years since their cancer diagnosis. So that's really quite, an astonishing number. However, if you think about, some early cancer survivors who might have attended this conference 20 years ago, there are not that many of you who are still alive today. So we still need to do a lot more. And then in terms of age, a couple of statistics here. So there are about 500,000 cancer survivors who were diagnosed as children, so before the age of 20, and about 2.1 survivors who were diagnosed as adolescents or young adults. On the other end of the spectrum, about 79% of survivors are age 60 and older. And so what that basically means is just the same way as we can't label people as cancer survivors and expect everything to be sort of homogeneously applied, but we also can't treat cancer survivors the same, right? These are very different age populations with different needs, with different issues, and then, of course, with different types of cancer. I think this might be the last statistics that I'm going to show. And so these are some distributions of cancer statistics. And so what you can see is that among men, the highest population of cancer survivors are those living with or beyond prostate cancer, melanoma, and colon cancer. Whereas for women, it's breast cancer. Wait, hold on. So yeah, the top one is what it is right now, and then what is expected. So for women, it's breast, uterine, and thyroid. And so the important piece here is that survivor statistics are also not the same as incidence statistics. So lung cancer is still a common diagnosis, but many patients with lung cancer do not survive long term. Although, exciting for those in the clinical field treating lung cancer is that there are now more targeted treatments that are available to treat lung cancer, and down the road, lung cancer may become a more survived diagnosis. And so this is the map of the number of cancer survivors across the US, and then you can see there the number of cancer survivors in Minnesota. So what is whole person cancer survivorship care? So this is a graphic taken from a framework that I developed when I spent some time at the National Cancer Institute. But what I I provided some sort of real-world definitions of what we mean in the field. So the first one is recurrences and new cancers. So that's basically watching for cancer to come back, to relapse, recur, or for a new cancer to develop. Side effects, which is physical effects, psychosocial effects, which is emotional health, health promotion, which basically means staying healthy, and chronic conditions, which is other health problems that may have nothing to do with cancer. And so what I will do is I will walk you through this and sort of demonstrate, exactly what I mean by whole person care and what you as survivors and caregivers can really be thinking about when you're discussing cancer survivorship care with your healthcare teams. So the first area is the recurrences and new cancers. And then oftentimes when you ask an oncologist or a patient, this is their main area of focus, right? I mean, you go to the oncologist's office and you get a physical exam, you may get some labs, you may get some tests, some scans, and everything looks good, and the oncologist says, great, you've got no evidence of disease, the cancer is not, moving, it's not coming back, I'll see you next year, right? Often what happens in an oncologist's office. And oftentimes that's what survivors also kind of expect. And that's what you really often focus on, which is, I don't want my cancer to come back. And the fact that the scans are clear, fantastic. But the important piece there is that treatment-related cancers can develop years or decades, needing attention, screening, and monitoring for symptoms. So for example, if you were treated early on in life, let's say for Hodgkin lymphoma, and you had chest wall radiation, that might, down the road, increase your risk of getting another cancer, like thyroid cancer or breast cancer or skin cancer. And so the important piece there is not only to think about Hodgkin and am I going to get Hodgkin again, but really we need to think about what other cancers am I potentially going to be at risk for, and what are the things that I need to do in order to monitor for that cancer so that we can catch it early. There are other cancers that may be related to chemotherapy. So after breast cancer, you get medications that may potentially increase the risk of hematologic malignancies like leukemias or myelodysplastic syndrome. So there too, it's just important to be aware and make sure that your doctors are monitoring you for other things, not just the original cancer. And so the next sort of bucket is physical effects. And so we know that cancer treatments can cause side effects. And it might be side effects today if you're getting treatment for cancer, but it might be side effects that start today but might continue for decades to come. So for example, one of the key examples here is neuropathy. So chemotherapy-induced peripheral neuropathy. And I see people shaking their head. I mean, that is such a common side effect that develops during cancer treatment. And for many, many people, once the chemo is done, the neuropathy goes away. But for other people, that neuropathy will last for years and decades and ultimately cause real issues with quality of life. And so those are the types of effects that we also monitor for and try to treat in a variety of different ways, some less effectively than others. And then there's the potential for late effects. So for example, a medication called doxorubicin is a medication often used to treat, or adriamycin is the other name for it, often used to treat many, many, many cancers. And for most people, they can go through treatment with doxorubicin or adriamycin and have no effects whatsoever. But then 10 years down the road, you develop congestive heart failure. You get swelling in the leg, shortness of breath, and that might have been due to the doxorubicin or adriamycin. So the important piece there is not to scare you or make you more nervous, but it's important to have the information, and I think that's why you're all here today, is to get the information that you need in order to live long and healthy lives. But also it's important that somebody is monitoring for those symptoms and for those conditions, and then manage those symptoms. And that might include a whole bunch of different people, including primary care, a cardiologist, a pulmonologist, a gastroenterologist, but also rehabilitation clinicians who are so key and so important in helping cancer survivors live long and productive lives. And then moving on to psychosocial effects. And emotional health concerns, obviously, are so common in cancer survivors. And these include a whole variety of different emotional effects, such as anxiety, depression. Fear of recurrence is such a big one and is so often not acknowledged or understood by clinicians. But also the importance of work, returning to work. How do you return to work? Can you return to work? Do you need to return to work part-time, full-time? Do you need to return full-time because you need your health benefits and insurance that otherwise you may not necessarily get? As well as family and relationships and sexual health, a topic that has kind of been completely under-discussed in cancer survivorship care, but really is based on multiple surveys with cancer survivors, is considered to be really important. And so the same way as we need to be aware about the physical effects of treatment, We also need to have awareness of the psychosocial effects and screen for it and manage it appropriately. And here too, it's your whole team. It's the primary care clinicians, it's the mental health clinicians, financial counselors, vocational trainers, and others. And then so the top 3 are sort of really cancer-related buckets, I call them. But we need to think of cancer survivorship again as a whole person. We need to think about survivors holistically. And so we can't forget keeping healthy and staying healthy and doing whatever you can to keep yourself healthy. I often say to survivors, you know, whatever treatments that you had and whatever late and long-term effects that you may have, it is what it is, right? And you can't, you know, right, like sort of with the exercise earlier, you can't go back and say, oh, I wish that I didn't have this, I wish that I didn't have that, right? I mean, we all do that, but the important thing is concentrate on what's now and concentrate on what are the pieces that you can control. And so we still need cancer survivors to focus on their diet, alcohol, in other words, good diet, reducing alcohol, exercise in whatever way possible. And so, you know, there are different types of exercise that cancer survivors can and cannot do. And so it's important to talk to your doctors and get a referral to an exercise physiologist if you can, and get a referral to a physical therapist if you can, so that you can continue working on building your muscles and rebuilding your muscles and flexibility and strength. Tobacco cessation, of course, and vaccination in a general sense. And so here too, we need to continue seeing primary care, your gynecologist, your dentist, especially those who had radiation therapy, so head and neck cancer survivors who had head and neck radiation, you know, will have lots and lots of issues with their teeth. And the important piece there is to seek dental care. And oftentimes it's challenging because not every dentist will want to, you know, do much, you know, once they find out you had radiation. And not every dentist is equipped to do dental care when you've had radiation. Seeing a dermatologist, so if you've had radiation therapy, right, I often say radiation therapy is like getting a whole lot of sun exposure, so you are at risk for skin cancer, including basal cells, and so seeing a dermatologist is so critically important. And then chronic medical conditions. So these are conditions that may have had nothing to do with the cancer or its treatment. Maybe before you even diagnosed with cancer, you might have already had diabetes. You might have already had blood pressure. You might have already had heart disease. But the important piece there is that some of your treatments may have worsened those conditions. So you may have had, you know, diabetes, but now with all the, you know, the potential weight gain, you know, that you got during your cancer treatment, going through menopause that you didn't expect to go through during treatment, stopping to exercise, or being told by the doctors when you have no appetite and you're nauseous, like, eat whatever you can, right? So there are other things that might have developed during cancer treatment that maybe worsened your diabetes or worsened your weight, you know, increased your weight or worsened your blood pressure. So the important piece there is really, like, even during your cancer treatment, you know, to make sure that you pay attention to the other medical conditions so that when the treatment is finished, if it's finished, you're not so far, you know, worse off than you were before. Because really, I mean, data does suggest that outcomes are different and are worse for people who have cancer but also have diabetes. And so doing whatever you can to really continue seeing your primary care doctor, continue seeing, you know, maybe your cardiologist and other specialty care is really critically important. And so those are basically kind of the main buckets, I call them, in holistic cancer survivorship care. And so as becomes very clear by the number of specialists that I mentioned in the previous slides, that care for cancer survivors and your sort of ability to manage your team of healthcare professionals becomes daunting. And this is a slide that I borrowed from NCCS, which is the National Coalition for Cancer Survivorship. They've just rebranded themselves, and they're called Cancer Nation. But this is one of their slides that they had put together, which basically demonstrates that that cancer survivorship care coordination is so challenging, that you have to manage your oncology team, right? And that might be your medical oncologist, your surgical oncologist, your radiation oncologist. And then you have your primary care doctor, and you might have your cardiologist, and you might have your gynecologist, and you might have your endocrinologist. Oh, and maybe a psychiatrist, a social worker, a physiologist, et cetera, right? And our healthcare system doesn't make it easier, that's right. And our healthcare system obviously doesn't make it easier for anyone, right? Because you go from one doctor to another doctor, and the doctor says, "Why are you here?" Right? How many of you have heard that before? Absolutely, right? Or if you go to a doctor or a facility that is not on the same electronic medical record portal, that's like complete desert, because they know nothing, they got nothing. The assumption is something would have come, but nothing really came. So here you are as, an exhausted patient trying to tell this new doctor why you are there. And that's assuming you know why you are there. So it makes it very, very challenging. And so this is, 2 years ago, I organized a workshop at the National Academies of Medicine, and specifically the focus of the workshop was on developing a multi-specialty, multidisciplinary workforce to care for survivors from the time of diagnosis through long-term survivorship. And this slide, I don't know if it fully comes through, is essentially a list of every type of specialist who might interact with a cancer survivor. And so the goal for this workshop was really in order to raise awareness among the healthcare professionals that they also need education and training in cancer survivorship. Because, like I said before, not every dentist will know how to extract teeth in somebody who had head and neck radiation. Not every cardiologist will understand the effects that chemotherapy or radiation therapy or preparation for stem cell transplant or, now the immunotherapy and targeted therapy will have on your heart. Not every physical therapist, knows how to, work on somebody who might have drop head syndrome after radiation for Hodgkin lymphoma. Not every physical therapist will know how to do pelvic floor physical therapy on somebody who had gynecological cancer and surgery there. And so what we are working on in the healthcare field is we are trying to develop education and training for clinicians across the board to really make them kind of more aware about the needs of cancer survivors, again, from the time of diagnosis through long-term survivorship and end of life, so that they are best equipped to take care of patients. And clearly there are challenges, right? I mean, there are challenges in their education, there are challenges in their training, but then also access. Right? So if the, the cancer center is 4 hours away from where you live, that presents a challenge. If the only physical therapist that can do real good physical therapy on your neck is 3 hours away, that presents a real challenge. So we need to continue to figure out how we can expand training, but then also, through video visits, through telehealth, through education that we can offer to our fellow clinicians, hopefully we can make a difference. And so since I am a primary care doc, in addition to being a survivorship, I sort of cross this on both sides, and I can really get the perspective on both sides. And so this was an editorial that I was invited to write, I believe in 2009. And this was in response to a paper that looked at survivors' preferences for cancer survivorship care and also clinicians' preferences for who should be offering cancer survivorship care. And this was a quote that actually came from one of my patients at that time. And, you know, she said to me, she was like, "Doc, I like you, but do I see you or do I see my oncologist?" And so this was sort of the beginning of me kind of thinking through you know, when do you see your primary care doctor and when do you see your oncologist? And so in early pandemic, in early 2020, I was asked to give a talk about primary care and why should a cancer survivor see a primary care physician? And so, of course, this was in, you know, early in the pandemic. And so Twitter at that point in time, I won't call it anything else, Twitter, was basically a real, you know, fantastic venue for those of us in the clinical field to connect with one another and connect also with the patient community. And so this was, in preparation for my talk, I put this out there. And I said, I've been asked to give a webinar to patients and caregivers, and it's called I Have Cancer, Why Do I Need a Primary Care Provider? And I said, seeking input, especially from patients and advocates, and looking to hear all perspectives. And so I then wound up getting a ton of responses, and I will not walk you through all of them. So here, PCPs are key to co-manage medical issues for cancer patients. PCP knew me before cancer and knows my complete history, which is invaluable. She listens without judging, doesn't ever react, but also doesn't ignore my concerns. You need a primary caregiver after diagnosis for the same reason you need one before diagnosis. And so I won't bore you with the rest of the quotes, but this is just to emphasize how engaged the community was in offering their perspective. And then this one is, I love my PCP. She often translates things my onc doesn't explain well enough. And a whole bunch of other quotes that came in, right? So because cancer drugs cause side effects such as high blood pressure, high blood sugar, thyroid issues, et cetera, that oncologists don't treat, you need a primary care provider for that. And so many quotes on that. And so I will then summarize, this one. Living with metastatic cancer and spending so much time at the cancer center at the hospital, I have fallen into the trap of not visiting a PCP. I know this isn't ideal. And this is also, right, I mean, what happens. And so the reason why this 2006 report was written by the Institute of Medicine, it was then called Lost in Transition, and it focused on patients who had completed their treatment, but then after they finished their treatment, they were like, done. And they weren't seen by their oncologist and they weren't reconnecting with their primary care provider. So that's one of the issues. On the other hand, there are also people who, you know, continue to see their oncologist but never kind of reappear in primary care until, you know, possibly years and years later. And so again, just to demonstrate the engagement that came up. And so just to summarize what came up from all of those quotes is that, of course, you need a PCP. And this is a long-term relationship that starts before cancer, translates information given by the oncologist, provides holistic care to the whole person, readily available for urgent care and prescriptions, offers emotional support, cares for other medical conditions, preventive care, and coordinates care. But of course, there are concerns and challenges. So primary care providers often have insufficient knowledge of the cancer and the treatment effects. I've already alluded to the fragmented healthcare system making communication and care coordination an issue. There is the feeling among cancer survivors and also oncologists that specialists are better able to handle issues, and that is probably true to some extent. It's hard to find a PCP. So I know that I live in sort of the mecca of healthcare in Boston. I mean, I think we have like more doctors that, then, I don't know, we have a lot of doctors. But no one can find a primary care doctor. There are no PCPs to be found, and I get calls all the time, will you please, take my patient, blah, 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 et cetera, right? Or you have, somebody's uncle is, calling to say, I really need a doctor. And so that's a real problem, right? I mean, it's a problem just with our healthcare system that we still need to figure out how to solve. And PCP is not always available. PCPs have many, many patients that they have to see during the day. They may not be able to call you right away. They may not have the support, in their office like the oncologists often do. They may not have the nurses and the medical assistants and others who can answer your phone calls. And limited PCP time. There was one study done many years ago that if a primary care provider did everything that they're supposed to do per guidelines, I think, don't quote me on this, but they had to work like 18, 19 hours a day in order to do everything that they're being asked to do, or maybe more. So it's a real challenge, in order for the PCP to do even the things that they need to do. Mind you, then learn something about cancer survivorship and the effects that cancer treatments may have on their patients. But it doesn't mean that they don't want to. And in fact, most studies really show that PCPs actually do want to take care for cancer survivors. They do have some reservations for sort of the more, complex cancer survivors, so adult survivors of childhood cancer who might have had a lot of cancer treatment, a lot of chemotherapy, radiation therapy, maybe a bone marrow transplant. They do find those challenging. But for sort of the more common cancer survivors in the community, breast, prostate, colon, primary care providers feel as long as they get some information from the primary care doctor, from the oncologist, then they would feel comfortable taking care of patients. So need to find or change PCPs, ask your oncology team or a local survivorship program, because the survivorship program will often know which primary care providers they have worked with and who they've liked and who their patients have liked. They may not be available to take on new patients, but you could try. As family, friends, peer support group, and ideally, it should be in the same healthcare system, electronic medical record. Because you're really, if you see somebody within the same system, within the same electronic health record, at least you eliminate the additional step of having to go over everything that has been done. At least you can just say, oh, it's, they're on the same system, you can just, upload the most recent chart, and then you'll be able to get the information. And then there are a few oncogeneralists. So oncogeneralists are basically people like me. So we're not really a thing, but it's people who are primary care providers who have some degree of interest, understanding, and education to care for cancer survivors. So when I first started in this area 20 years ago, there was basically, there were two at that time. So Kevin Effinger, who I understand has spoken to this group in the past, and Ava Grunfeld, and Ava was in Canada. And so now there are people in my cohort that have been doing this kind of work, and now we are mentoring a new cohort of people who are primary care providers who are really sort of the emerging oncogeneralists. And so many of these oncogeneralists do work in cancer survivorship programs across the US. But these oncogeneralists can't take care of everyone, right? It's sort of like you can't have a geriatric doctor who takes care of every older person. That's just not possible. And so, but these healthcare providers are able to educate others, and they're able to take care of patients who have some additional needs that, that a regular primary care provider can't offer. And then, of course, seek an appointment and establish fit. There's a need for communication and care coordination. Like I said, same system, electronic health record helps. Ask specialists, ask specialists to CC the PCP. So, and make no assumptions and vice versa. So a key piece that comes up for me all the time is, a patient of mine is, seeing a medical oncologist, radiation oncologist, a cardiologist, et cetera. And the assumption by the patient, the survivor, is, well, of course my primary care doctor knows and gets a note about all of this. And what I find time and time again is that even if we're in the same system, I most commonly don't get CC'd on any of the visits. And in fact, there are some healthcare systems that are trying to reduce burden and burnout among healthcare professionals and are basically asking people, don't CC, because it adds more in my and other in baskets. And so the idea is that just don't CC, because then that adds more work to your doctors. So just be aware of that and make no assumptions. So when you see your primary and your primary knows nothing, it's not necessarily because they just, avoided or they didn't read the materials that were sent to them. It's just that they didn't get it. So whenever you see anyone, any of your specialists, just say, can you make sure you CC my, my primary care provider? And then when you go to your primary, or if you're on the portal, love the portal. If you're on the portal, just send a message to your primary and say, I just went to see the cardiologist. Would you take a look at his notes? So just kind of keep people in the loop. And then patient portals, and then maintain regular care with the PCP to build trust and a long-term relationship. And then last, it's okay to change a PCP, assuming you can find one. And so ending the primary care piece with these two, I think, really great quotes also from that Twitter pseudo-survey. This is from a patient, and she said, a knowledgeable PCP is vital to your care during and after treatment. Everyone has a job to do. You are the patient, oncologists focus on your cancer, PCP, what's going on with your heart health, conditions before cancer, toxicities, how you stay healthy, etc. And then this is a quote from a primary care doc. Can expect PCP to take a comprehensive view of health and values to help patients navigate challenging decisions ahead, partner with their cancer specialist, and you to coordinate and sometimes translate for you to continue to provide longitudinal care before, during, and after. And then here is just a graphic that you don't necessarily need to really read, but it's just a reminder for all of us that not all survivorship care happens in the healthcare delivery system. And a lot of survivorship care happens in the community. And so I know that there are some community groups that are present here and advocacy organizations that are present here. And it's important just to know that these people are there, and the services that they provide and the resources that they provide in the community, are there and can be actually oftentimes more helpful than what you might get, like, for example, physical therapy or psychosocial therapy or financial support from a cancer center. And then, of course, relying and seeking any advice and support and feedback from your local cancer survivorship program. And then I wanted to, and just to also acknowledge again that there are a growing number of survivors who are living with advanced and metastatic cancer. And so historically, we would sort of not put these people into the survivorship language or lingo. And again, this is not meant to label anyone or call anybody a survivor when they don't feel like one. But the important piece for us here is to also acknowledge that there are more and more people living long-term with advanced and metastatic cancer. And so we really do need to think about their care in a holistic sort of way and not only focus on their cancer, because people can live with metastatic cancer now for 10 years. And so we still need to pay attention to the other aspects of their lives and not just on the cancer itself, and really also continue to provide support to their caregivers. And just to end, to say that survivorship changes over time. The needs change, and care should change, and it's okay to ask for help again. You know, you might be in treatment now, and you have certain needs. A year from now, you might have different needs. 5 years from now, you might have completely different needs. 20 years from now, you might have completely different needs based on how long it's been, based on the late and long-term effects that you've had, based on what other cancers you might have had as a result, based on where you are in your life course, you know, and the challenges that you may have now that you didn't have then. If you were diagnosed as a child and knew nothing about your cancer, and now you're an adolescent or a young adult and you're sort of learning how to navigate life on your own, and you want to learn more about your cancer and educate yourself in that way. So it's important just to kind of just know that this is a cycle, and it's always okay to reach out. And so again, I wanted to thank you so much for inviting me to present to you today. I'm honored to be here at this 20th anniversary conference. I know many of my colleagues and mentors who have spoken here in the past, and I hope that this survivorship meeting happens for 20 more years, but that over this time we make really important strides and address some of the holes that are left in our healthcare system, in our understanding, and in our treatment. So thank you so much. Yeah. And I've left about 10 minutes for questions.
So I've got a microphone, and I would say thank you so much for that really inspiring and great and thorough talk about how do we keep staying well. Open this up to questions for people.
Hi, thank you for your presentation. It was very informative, so I really enjoyed it. I have one quick question. You had mentioned that colorectal cancers and breast cancer is growing in younger patients now. Do we have any idea scientifically why this is happening, or if there are any other, progress made in this area?
Yeah. So, yeah, I mean, a really fantastic question. The question is, why is there a growing incidence in some cancers? Really, the main one is colorectal cancer in the younger patients. And there's a lot of research that's happening in this regard. I was just at a meeting recently in Orlando. It's the NCCN, it's the National Comprehensive Cancer Network meeting, and sort of the expert on the panel essentially said and confirmed what I was thinking, which is that it's probably dietary. To a large extent, right? I mean, I think for colorectal cancer, that actually does make sense. And so, whatever it is that's in our foods, whether, processed foods, chemicals, pesticides, who knows? It's there. And we need to continue to, target, and I think also eat our best diet. And as a result of the changing demographic is actually why the recommendation for when to begin screening for colon cancer has been reduced. It has always been 50 for many years, for as long as I've been, in medicine. And then just recently went down to 45 as a result. And of course, that's for the average population. If you have family history, if you had radiation to your abdomen or pelvis, then the recommendation actually even goes down. But we're still learning, but probably diet.
I'll just put a plug in as you're asking that. Through the doors in the back, there's a table with information about the 10,000 Families study, which is a Minnesota cohort actually really trying to understand cancer and the environment in the state. So if any of you are interested, stop by the table. Other questions?
I'm a retired family practice doctor. I'm just wondering, what do you do to promote the onco family practice process? And are there many people in Minnesota who've accomplished this program? And how long does it take to do it?
Yeah, so the question is how do we promote and train sort of these onco primary care providers? So there is not a formal program at the moment, although some programs are developing. So University of Cincinnati just launched an onco primary care fellowship. And so it is a formal program that is targeting general internists or primary care providers who are interested in oncology. And then in addition, there are also, there's sort of growing little pockets everywhere around the country. And at the moment, what we're doing is so the National Cancer Institute actually put together this group called Inspire, which is essentially meant to train and educate primary care providers about cancer survivorship. It's focused on research, but within that effort, we're also developing competencies for primary care providers in cancer survivorship, sort of across these domains that I outlined, essentially saying these are the pieces that you need to know in oncology. And it even starts with, these are the terms you need to know. Like, what is a bone marrow transplant? What is an allo transplant? What is an auto transplant, right? Like, I think a lot of primary care providers don't actually know graft versus host disease. So it's even just starting with the definitions and then going through, the physical effects, the psychosocial effects, et cetera, et cetera. So it's still, we're like I alluded to before, I mean, when I started, there was really no one. Now there's a growing body, right? And it's sort of like if you tell your friends and they'll tell their friends and so on and so on. And so that's what we're really trying to do, is each one of us is trying to educate and mentor local people so that we can kind of continue moving forward. Is there anything going on in Minnesota?
Yeah, I was going to say, I'll just add to that. I mean, this is something Dr. Nekhlyudov and I talk about on a regular basis, kind of nationally and internationally, of like, how do you have a certification, for example, to find a primary care doctor who knows more about survivorship. We haven't quite figured out all the pieces. What I can say locally is that we are training our next generation of physicians with information about it. So there are rotations right now when medical students come in, they're learning about late effects, whether they go into surgery or ophthalmology. There's a specific curriculum as well. Dr. Sadek has some through the pediatric program. We have some through internal medicine as well. So I would say it's on a multiple prong approach of like, how do you have these, how do we work across our workforce for it? Kareem, I think there's a question in the back. Yeah, if you have other ideas, let me know.
Yes, join the effort.
Yeah. Hi, thank you so much. This is wonderful. And I'm a breast cancer survivor navigating stage 4 breast cancer. I'm also a caregiver to my mom, who also had breast cancer actually after I got it. So there you go. And she's got these compounding health issues, right? Like, we're navigating just more and more health issues, and and she's got a wound that won't heal. And and she's been bounced around to wound care, to all these different specialists, and then it's also her heart and all these things. And she's 7 years out, and I'm trying to figure out how to advocate for her. And I'm like, who takes point, right? Like, is there a care advocate that you can find? Is it your primary care, your oncologist? And I've been in appointments where, with a plastic surgeon, and I'm like, who is taking point on managing this? And then it starts to kind of fall into place. But as a caregiver, how do we, help people, but not I can't take on her medical history, and then I can't take on all these things, but also try to, have her tap into what are the resources that are available to her that, will help her out.
Yeah.
Thanks.
Well, thank you for sharing that. And it's, particularly, I mean, it's tough to juggle both. Sounds like you need like sort of a family support as well. So yeah, no, I mean, I think that's a really common and challenging issue. And so my general advice is have a frank conversation, probably first with the oncologist, and then also with the primary care provider, because the resources and the supports that they might have might be different. So I think typically the cancer centers will have more support available. They have more financial support available, they have more nursing available, they have more psychosocial support available, transportation, et cetera, et cetera. So I always, say like just kind of get the information from your oncology team to see what's available there. But then also have a frank conversation with your primary care provider, and that's also where sort of that long-standing relationship helps. And so especially if your PCP has known your mother for years, they're invested really in her health and her well-being. And so I think they will be more likely to want to support and do whatever they can. The resources within a primary care office are usually more limited, but they might be available. The last thing that I will say is also more cancer centers are now have navigators. I don't know to what extent it's available here, but nurse navigators has now been like sort of shown to be really helpful for cancer care. And there is some funding from the government to help fund cancer nurse navigators. And those are the people that can also kind of help you make appointments or help assess the needs and then help guide you in some way or another. And then also the community, right? And sort of, going to whatever community resources that are out there. But I would say it should be, in this situation, it probably is a team between the oncology team, the oncologist, and the primary care provider.
And it is really complex. I think we all would agree with that. So part of our system, it's really our nurse coordinators who are the navigators. That's the term we use. So if you don't know who that is, I would figure out who that is. And sometimes they don't know what your needs are or how much you're doing unless you speak up about it. We probably have time for one more question, and then we'll move to our breakouts.
I know well-being programs such as like the program here at the university rely on participation to make it successful. I'm hoping that we are going to see very soon cancer survivorship as a category of well-being worthy of points just as much as the bike ride or the walk. Or I just think it's a well-being point that's been long in being awarded to either patients or caregivers. And I hope it becomes a greater HR concept.
Perfect. I second that. So yes, so cancer survivorship, we really do need to think about cancer survivorship from the time of diagnosis. And so a point that I recently made at this conference is that the type of treatment that a patient receives will affect survivorship. The type of psychosocial care somebody receives during treatment will affect survivorship. The amount of information you're given, and the attention you're given during treatment will affect survivorship. And so I think that really survivorship does begin at the time of diagnosis. Symptom management and supportive care starts at the time of diagnosis. And it also needs to continue after treatment ends, right? Like, patients can't fulfill, kind of complete their treatment, ring the radiation bell and then sort of be done, right? Sort of the course continues. And I think that it's important that the entire healthcare system, that oncologists and primary care providers and survivors and their caregivers sort of really understand and really focus on the whole person. Thank you so much.